This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Greg Cooper from the Norton Neuroscience Institute in Louisville, Kentucky. I'm speaking today with Joseph Therriault of McGill University in Montreal, Quebec, Canada, about his paper published in Nature Aging, Diagnosis of Alzheimer's Disease Using Plasma Biomarkers Adjusted to Clinical Probability. So first of all, Joseph, thank you for being here with us.
Thanks so much for having me back on the podcast, Greg.
So I wonder if you can start by, first of all, just telling us the main message of your paper.
So our paper deals with the question of how we should be interpreting these new high-performance plasma biomarkers for Alzheimer's disease clinically. So in other words, what does a positive plasma biomarker test tell us, and what does a negative plasma biomarker tell us? And as we're going to get into throughout this conversation, what we have to do is we have to interpret this plasma biomarker in the overall clinical context of the patient. So that means their history, their age, and what kind of clinical syndrome they fit into, if they fit into one. And if we can do that, if we can combine the plasma biomarker information with their clinical syndrome, which kind of makes up what we'll call the pretest probability, we can avoid needing to use PET scans or invasive lumbar punctures in the majority of cases.
So really, part of the importance of this is it may be an easier, a more accessible way to check these biomarkers.
That's exactly right. I think a lot of patients aren't very excited, and understandably, about a lumbar puncture, and PET scans can be expensive. And my understanding is a lot of patients have to pay some amount out of pocket for an amyloid PET scan, so that can be prohibitive.
That's absolutely correct. So before we get into the meat of the paper too much, there are a lot of terms that I think neurologists are going to be familiar with, but it still might be worth defining them a bit. Sensitivity, specificity, positive and negative predictive value. Can you say just a little bit about those?
So sensitivity is the ability of a test to correctly identify people who have the disease that you're looking for. In our case, if we have an example of 100 people who we know have Alzheimer's pathology, so in this case, when we say Alzheimer's pathology, I mean amyloid plaques and tau tangles, a blood test that has 90% sensitivity would be positive in 90% of those people. So those are the true positives. And it would be negative in 10 of these 100 people. So those are the false negatives. So there's the true positives and the false negatives. Specificity is the other side of that coin. It's the ability of the test to identify people who don't have the disease. So if we have another 100 people who we know do not have Alzheimer's disease pathology, a blood test that has 90% specificity will be negative in 90 of those people. So those are the true negatives. And it would be positive in 10 people. So those are the false positives. Sensitivity and specificity are pretty often confused with positive and negative predictive value, but they're a little bit different. Positive and negative predictive value are more what we need clinically, because we don't know whether the person has the disease or not. So, and we need the test to tell us. So a positive predictive value is the probability that the patient that's in front of you with the positive test result has the disease that you're looking for, in our case, Alzheimer's disease. And negative predictive value is the probability that someone with a negative test result truly does not have the disease you're looking for.
And so how does the underlying disease prevalence play into that?
Predictive values are a lot more helpful clinically, but the reason that not every paper reports them is that they're harder to calculate. And because the predictive values change with the prevalence of the disease, and prevalence of a disease is not just one number in a population, right? The likelihood that a specific patient has the disease you're looking for changes with respect to the age of the patient, with respect to their clinical history, maybe their family history, and what clinical symptoms they have. So all of these things taken together influence the prevalence or the pretest probability of the disease of interest in a patient or someone who looks like the patient that you have in your room. As prevalence of a disease goes up, or the pretest probability of a disease goes up, your positive predictive values will also go up, because it's easier to rule in a disease that's very common. And the other side of that coin is, as prevalence goes up, it's harder to rule out a disease. So your negative predictive values are going to go down. So in a situation where there's a low prevalence of a disease, or it's a rare disease, or it's maybe the patient has specific clinical symptoms that make some diseases very likely and other diseases lower on the differential, if you want to try to maybe rule in one of the lower probability diseases, even a really accurate blood test may not be good enough because it's so rare. So those might be situations, as we'll discuss later, where you may need to order a lumbar puncture or an amyloid PET scan.
Getting into the details of the study a bit, can you start by describing the study population that was used in your paper?
So our study had 2 steps, basically. And in the first step, we got estimates of the sensitivity and specificity from a number of the different plasma biomarkers that we investigated. And we did that by looking at 11 different observational cohort studies from 6 different countries around the world. So that was Canada and the US, a few countries in Europe, and in Asia as well. And what we were able to do is, by devising a standardized way of figuring out who has a normal plasma biomarker result and who has an abnormal plasma biomarker result, we got sensitivity and specificity values for all the plasma biomarkers in our study. So that was step 1. In step 2, we applied the sensitivity and the specificity estimates to the known prevalence rates of Alzheimer's disease pathology. So in this case, I'm referring to amyloid beta PET positivity in people with different dementia syndromes at different ages. So with the sensitivity and the specificity that we know for the different plasma biomarkers we looked at, then we have our different prevalences for the different diseases and how those change with age and other factors like ApoE. And then we were able to estimate for a patient with mild cognitive impairment who's between 70 and 75, what's the probability that someone with a positive p-tau217 actually has Alzheimer's disease pathology. And the prevalence estimates of Alzheimer's disease pathology were based from meta-analyses of memory clinic and research settings. And we also replicated a lot of the analyses using population-based studies.
You looked at 5 individual plasma biomarkers. Say just a little bit about what those were, but also how you landed on those 5 particular biomarkers.
We looked at 3 phosphorylated tau biomarkers. So that's p-tau181, p-tau217, and p-tau231. And then 2 non-tau biomarkers. So that's GFAP, which stands for glial fibrillary acidic protein, and NFL, which stands for neurofilament light chain. So when we were designing the study, the time it took from the design stage to the publication stage was pretty long. And when we were designing it, we were starting to have a pretty good idea that p-tau217 was the best plasma biomarker for Alzheimer's disease. We knew it was the best overall, but we didn't know at the time whether maybe there's something else any of these other biomarkers can tell us. Maybe that phospho-tau can't, maybe in a specific scenario. So that's why we looked at a lot of other common ones. I'll say just a couple of them really quickly. So plasma GFAP, we were interested in because it's quite sensitive for Alzheimer's disease pathology, but the problem is it can also be high in a lot of other diseases. So it's high in people with traumatic brain injury, people with hemorrhagic stroke, Parkinson's disease, MSA, and PSP. So in a differential diagnosis scenario, it may not be very useful. And the same is true of NFL, where it's a marker of axonal degeneration and it's elevated in almost every neurodegenerative disease. So again, not good for telling us whether if a patient with suspected neurodegenerative disease has Alzheimer's disease or not. And then finally, we decided not to look at the plasma A-beta 42-40 or any plasma A-beta biomarker, whether a ratio or not. And the reason is that simply put, in blood, they're just not very good biomarkers. In CSF, they're excellent. But in blood, because the amyloid precursor protein is expressed in the periphery of our body, it's expressed on platelets and muscle cells and a number of other cells. These confound the signal of the A-beta ratio blood test, and it makes it very hard to know whether the signal that we're getting is this from the brain or is this from the body, and it makes it very hard to know. So the tests are not very accurate. And on average, patients with Alzheimer's disease dementia and controls, they're only about 10 to 15% different on their A-beta plasma biomarker. So they're pretty close on average. And that's very hard to make an accurate test when the two means are so close. But to give you another example to contrast that with, the p-tau217 biomarkers are about 300% different in the different groups. It's a very different scenario, and that's why that biomarker is so much more accurate.
Would you mind just to give us a high-level analysis of your results?
The main message is that the plasma biomarkers, even the really high-performing biomarkers, need to be interpreted in the overall clinical picture. So that means the patient's clinical syndrome, their age, and if their ApoE4 genotype is available, that's great information to use too. So I'll illustrate the main takeaways with a couple examples. I think that'll be helpful. So one case would be an example where you strongly suspect Alzheimer's disease pathology. So that would be in a patient, for example, who meets clinical criteria for what we call probable Alzheimer's disease, what we now often call Alzheimer clinical syndrome, which would be progressively worsening amnestic memory impairment that interferes with daily life and activities of daily living, and gradual involvement of other cognitive domains. And here, your clinical suspicion from that story, that anecdote, is already high. And then if you have a positive phospho-tau217 biomarker in that patient, your positive predictive value, or the likelihood of that patient having Alzheimer's disease pathology, is above 95%. So that's very, very high. But what if the p-tau217 result is negative in that patient? Because your pretest probability was so high, a negative test result shouldn't make you confident about ruling out the disease quite yet. Even if the test is very accurate, your pretest probability was so high that you're going to want to do a follow-up test. So that's either amyloid PET or cerebrospinal fluid. It would be wrong to rule out Alzheimer's disease based on the plasma biomarker in that scenario. But because the pretest probability is high, if the test result is positive, you could pretty confidently rule it in. You're already thinking so, and you got a nice confirmation. But I'll give you a different example now. So let's say you have a younger patient where the clinical syndrome is maybe more compatible with behavioral variant frontotemporal dementia. Of course, it's possible that the patient has, a frontal variant of Alzheimer's disease, right? It's what some people call maybe a behavioral or a dysexecutive variant. It's possible, but it's less likely. It's lower on the differential. So in that patient, if you have a negative plasma biomarker, so a negative, let's say, phospho-tau217, your negative predictive value is over 95%. You can be pretty confident in ruling out Alzheimer's disease as being present in this individual. But what if the plasma p-tau217 is positive? Well, because your pretest probability is pretty low, if you have a positive test result, it's not good enough to say Alzheimer's is present or is driving the symptoms here. So that would make you want to think in that scenario, you'd want to order an amyloid PET scan or a lumbar puncture to confirm Alzheimer's pathology.
It really does come down to that pretest probability.
That's right.
And if your pretest probability is high, a positive result may stand alone. A negative result, you'd need to confirm that. And then quite the opposite. If your pretest probability is low, you would want to confirm a positive test. A negative test, that might stand on its own. Do I have that right?
That's exactly right. And we have tables that have positive and negative predictive values for different clinical syndromes. So you could refer to those.
Yeah, I think that's table 2, which will now be a standard reference, I think, in my clinic. I ask you also about p-tau181. You mentioned in the paper that there can be a lot of variability in the laboratory performance on that test. I'd love to hear a little more about that and to, I guess, get your reassurance that that does not plague p-tau217 in the same way.
So I'll start by answering the second one. It doesn't plague 217 in the same way, which is reassuring for everyone. We recently conducted a systematic review and meta-analysis of all the plasma biomarker studies for Alzheimer's disease pathology. And what we found is that all the 217 results are basically neck and neck, within 1 or 2% of each other. And that's at the level of statistical noise. The C2N is one of the companies that offer them. Their phospho-tau217 assay might be 3 to 5% better than the other ones. And they have some more high quality studies than some of the other biomarkers. But overall, all the 217 tests are very high performing. Unfortunately, the same isn't true for p-tau181. It's much more variable. And I'd like to take this opportunity to mention that if you have the ability to order a phospho-tau217 test, I don't think there's any value in going with a 181. I think the 217 is just more sensitive and more specific in every scenario that we've seen. And I think it's pretty understandable, and maybe we can discuss this later. There's a lot of different blood tests out there, and someone who's maybe hasn't been following this for a long time, it's understandable that you have the option of the different ones, but I want to reassure that phospho-tau217 is the blood test that we should be working with.
Let me ask you one other thing. It looked like ApoE genotyping helps improve our accuracy. Should we be doing that fairly routinely now if we're doing biomarkers, or what's your feeling about that?
The phospho-tau217 test is as accurate either way. But what the ApoE does really well is it changes your pretest probability. So if you know someone has one E4 allele, your pretest of Alzheimer's disease being there, of amyloid pathology there, goes up a lot. And if they have two E4 alleles, I mean, it's very, very, very likely, is one way of putting it, that they have Alzheimer's disease pathology. So what ApoE is really, really good at is it helps narrow your pretest probability, and it'll make you more confident in your estimates. So the other side of that is if you have someone, where you're not super sure whether Alzheimer's disease is going on, and then you see they're negative for E4, and then you also have a negative phospho-tau217, now you're a lot more confident in that result. So in the supplementary of our paper, we have estimates for PPV and NPV. If you happen to know the E4 result of your patient, that's one way you can refer to those tables. If not, ordering it will be a helpful thing as well.
You also make an important point, and I think it's worth reiterating, that multiple neuropathological processes are often present, particularly in older individuals with cognitive symptoms. And so plasma biomarkers alone can't determine whether Alzheimer's disease pathology is the driving force behind a particular clinical syndrome, correct?
That's correct. And it's important to keep in mind, it's a limitation of the biomarkers, right? We know from a lot of neuropathological studies that in most individuals who have dementia, when they have an autopsy, they usually have more than one, and sometimes, three or more different neuropathological proteinopathies. And a neuropathologist will be pretty good at telling you, okay, this one is, I think, the most severe and therefore driving the symptoms. But the plasma biomarkers we have right now can't give us that. Especially the phospho-tau biomarkers are really, really good, but they're an indication of whether Alzheimer's disease is present or not. And they track somewhat with the severity. They'll become more abnormal as the disease is more advanced. But, relying on that is tricky. So at the moment, they can tell us whether Alzheimer's disease is there, but whether Alzheimer's disease is really in the driver's seat, so to speak, and was really the main thing causing a patient's symptoms, at the moment, we're not able to do this. I do think that in the next few years, whether that's 5 or 10, we're going to be able to do this with alpha-synuclein and then other biomarkers of other neurodegenerative diseases, but we're a little bit away from that right now.
So understanding all of that, where do you see this fitting within the standard practice of the neurologist right now? How should we be making use of these biomarkers?
So I want to take a moment here to just say that phospho-tau217 is the test that you should be ordering. So that's either ordering a phospho-tau217 or a panel that includes phospho-tau217. I mention that because there are some tests that, for example, include phospho-tau217 and ApoE, or phospho-tau217 and plasma A-beta or something like that. So at least having phospho-tau217 is the way to go. That's the first thing I want to mention, because there's a lot of services that allow you to order all these tests. But one of them is way better, and they don't really make that clear. So that's point number one. Point number two is that even with a great blood test like phospho-tau217, clinicians need to be careful not to rule in or to rule out Alzheimer's disease too quickly just based on the blood test result. It needs to be interpreted in the overall clinical context. And that means, like you said earlier, understanding what was the pretest probability, and now with the result that I have, what's the post-test probability? So when the pretest is high and you have a positive test, you probably don't need to do an amyloid PET scan or a lumbar puncture. I think that can make you confident enough to make a lot of the decisions you need to make. If your pretest was low and the phospho-tau217 result is low, you can pretty confidently rule out Alzheimer's disease. But in the other scenarios where, in other words, if the blood test isn't really compatible with your clinical suspicion or your impression, you're going to want to order confirmatory testing. So that's either a PET scan or cerebrospinal fluid assay.
Makes a lot of sense. Anything else you'd like to share where you think this field is going, what we're going to see in the next few years?
One thing that I'm really excited about is there's been some recent development of plasma assays that correlate a lot better with the deposition of insoluble tau, so tau neurofibrillary tangles. Phosphorylated tau correlates a lot better with brain amyloid, and some of these other biomarkers like MTBR correlate a lot better with tau tangles and a lot better with the symptoms of Alzheimer's disease. So those are being developed very actively. And I think in the next 5 years or so, that's a tool that's going to be able to tell us very well whether Alzheimer's disease is driving the clinical symptoms of a patient or not. So that's one thing I'm really excited about. And the other is assays for the other common degenerative pathologies. I think alpha-synuclein is getting pretty close. And that's going to be very, very cool to be able to assess and narrow our differentials and help our patients.
I agree. It's always been frustrating, even for someone that follows this closely, that p-tau217 tracks with amyloid instead of tau.
Yeah.
It's counterintuitive, isn't it?
It is. It's counterintuitive. And it was odd because when we started studying this biomarker, we were looking at it and people who were amyloid positive had no symptoms and no tau deposition. They had high p-tau217 levels. And this, wait a minute, because at the time the model was different. And then we thought, hold on. And then the model of the disease has shifted a little bit since then.
Yeah. Amazing. This has been a great conversation as I anticipated. Thank you again, Joseph, for being with us. And thank everyone for joining us on the podcast. Again, it's been our privilege to hear from Joseph Therriault of McGill University in Montreal about his paper published in Nature Aging, Diagnosis of Alzheimer's Disease Using Plasma Biomarkers Adjusted to Clinical Probability. Thank you.
Thanks so much.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.